All right. Um, Hi, Judy. I can see you on the screen. All right. So I wanted to thank everyone who's come here and braved the terrible rain though we've been having for quite a while. So thank you, especially to the VA folks. That was pretty brave. Um, and then all of you who are watching remotely, I'm glad that you were able to join us. So today it's my great pleasure to introduce Dr. Emily Lau. Before I do that though, I wanted to remind everyone, this is the last Friday grand rounds of the academic year. And the Blount lecture is going to be in a few weeks. It's on Wednesday, June 14th, and Dr. Clyde Yancey is coming from Northwestern to give that honorary lecture. There's also a reception the day before. So if you have not gotten those invitations, let us know and we'll make sure that you do. So it's my great pleasure to introduce Dr. Lau. She's a cardiologist and an investigator at Mass General. She leads a clinical and translational research program focusing on understanding how biologic sex differences and sex-specific risk factors contribute to unique cardiovascular phenotypes in men and women. She received her MD from Brown and then got a master's in public health from Harvard. She trained in internal medicine at Brigham and Women's and also served as a chief medical resident. She subsequently completed cardiovascular disease fellowship and advanced echo training at Mass General. She's the PI of several research studies examining the role of inflammation and menopause and HFpEF pathogenesis in women and the use of deep learning to predict adverse pregnancy outcomes. Her research is supported by multiple groups, including the NHLBI, AHA, and an MGH Spark Award. So clinically, Dr. Lau specializes in women's cardiovascular health and serves as the director of the Cardiometabolic Health and Hormones Clinic within the Women's Heart Health Program at MGH. So it's my great pleasure to introduce her. I hope you'll enjoy this talk. And once again, remember that the Blount lecture is in a few weeks, and there was a cancellation that came through Alex Sassano. It was just because that was a duplicate. We have not canceled Blount. So it is still on June 14th. Thank you.
Well, thank you so much, Pratiti, for that very kind introduction and for the warm welcome that I've had here so far. Everywhere I turn, everyone keeps apologizing about the weather. And I said, well, this is every day in Boston, so it doesn't bother me. Well, I'm really excited to be here today to discuss a topic that's near and dear to my heart, and that is how can sex differences teach us about heart failure with preserved ejection fraction? So to begin, I'd like to kick off by considering two terms that we often toss around a lot and conflate, and that's sex and gender. Sex is a biological variable that's really determined by an individual's genetic complement of chromosomes. And variations caused by sex can influence everything from disease pathophysiology, disease presentation, and even response to therapy. By contrast, gender is a multidimensional social construct, and it's really related to the norms and societal expectations that exist related to being male or female. And gender constructs can also influence health, like things like access to healthcare, perception of risk, and even implementation of preventive and therapeutic strategies. And for an individual clinician, a patient's gender can certainly influence how a clinician interprets their symptoms, diagnoses disease, and prescribes treatment. Now, sex and gender interact a lot on many different levels. For example, genetic sex can influence behavior. And then conversely, genetic or gendered behaviors can actually modify gene expression. Now, for the purposes of today's talk, I'll be using the term sex to represent biologic sex that's assigned at birth. And I'm going to be using sex as a binary variable. Interestingly, most clinical studies actually rely on self-identified gender as a proxy for biologic sex. So I'll be using the terms male and female and men and women interchangeably. Now, as I've just outlined to you, this approach, and I acknowledge that this approach really doesn't capture the complex interplay between sex and gender. I think that's an incredibly important topic and deserves its own dedicated series of talks. All right. So I think for anyone who's submitted an NIH grant, we've all been asked to demonstrate how we have incorporated sex as a biological variable into our research design, our analysis plan, our reporting. But actually, the study of sex differences is a pretty nascent field. It was only in 1993 when Congress passed the NIH Revitalization Act that mandated that all funded investigators included women as well as men in NIH-funded clinical research. So that was really only 20 years ago, wasn't that long ago. And then it really wasn't until almost 20 years later when we saw the next piece of real substantive legislation related to the study of sex differences. So in 2012, the FDA Safety and Innovation Act mandated that the FDA review all applications for drugs, biologics, and devices for the inclusion and analysis of key demographic subgroups like sex, race, ethnicity, and age. And finally, in 2014, the NIH actually announced a change in their research policy calling for the balancing of sex in all cell and animal preclinical studies. So why should we be studying sex differences at all? I think the 2001 Institute of Medicine report nicely made a case for the study of sex differences. And what they wrote was that being male or female is an incredibly important basic human variable that affects health and illness throughout the lifespan. And for that reason, sex should be considered when we design and analyze studies in all areas at all levels of biomedical and health-related research. And I argue that we study sex differences because one, over half of our population are women, and two, understanding sex differences actually has the potential to advance our mechanistic understanding of disease conditions that influence or that affect both men and women, particularly those conditions that may manifest differently in men and women. Now, the potential for the study of sex differences to advance mechanistic understanding is really no more evident than with heart failure with preserved ejection fraction. As we all know from taking care of patients in the clinic and in the hospital, HFpEF is a major public health concern today. It's now the leading form of heart failure, and its prevalence and incidence continue to rise. And yet, our mechanistic understanding remains pretty crude, and there are very few effective targeted therapies to treat it. One of the most striking features about HFpEF is its female predominance. These are data from about 700 participants in the Framingham Heart Study who were hospitalized for acute onset heart failure. And among clinical risk factors like coronary heart disease and atrial fibrillation, female sex was actually the single risk factor that most strongly distinguished heart failure with preserved ejection fraction from heart failure with reduced ejection fraction. Since this initial study, many subsequent analyses have actually replicated this observation. Despite a similar lifetime risk of developing heart failure in men and women, the prevalence of HFpEF is markedly higher in women. In fact, about 55 to 65% of women in all heart failure registries have HFpEF. And among HFpEF hospitalizations, women outnumber men 2 to 1. Differences in cardiac structure, adaptation to physiologic stress, and comorbidity burden have all been hypothesized to potentially explain this female propensity to HFpEF. So here's our roadmap for today's talk. First, we'll explore sex differences in HFpEF risk factors, which might explain why and how women are more susceptible to developing HFpEF. Next, we'll discuss HFpEF in women, and specifically, I want us to consider, does HFpEF in women actually represent a distinct phenotype? Third, we'll review the therapeutic implications of these sex differences. And finally, we'll end with a discussion on mechanistic insights. So let's begin by unpacking how cardiometabolic disease contributes to the female susceptibility of HFpEF. So as I just mentioned, HFpEF is an increasingly common clinical condition, but mechanistic understanding remains very limited. The current prevailing paradigm proposes that HFpEF is a comorbidity-induced pro-inflammatory state. And what that means is that, in contrast to HFrEF, which is really driven by a loss of cardiomyocytes in the context of something like a myocardial infarction or some other toxic insult, HFpEF is really thought to be a systemic disorder. So what this paradigm proposes is that cardiometabolic risk factors like diabetes, hypertension, obesity induce a pro-inflammatory state. And it's activation of this inflammatory cascade that is then thought to contribute to cardiac functional changes like abnormal microvascular and endothelial function, impaired nitric oxide signaling, and increased production of profibrotic cytokines. And together, those changes are thought to converge to contribute to cardiac structural changes like LV hypertrophy, interstitial fibrosis, and ultimately the clinical syndrome that we know to be HFpEF. So with that framework in mind, I think it's really notable that across all studies of HFpEF, from clinical observational studies, clinical registries, clinical trials, women with HFpEF have many more comorbidities than men. Here are data from about 4,500 women and 4,000 men who were enrolled in one of 3 HFpEF clinical trials, including Charm Preserved, I Preserve, and TopCat Americas. And I think what you can appreciate here is that women with HFpEF were older, they were more likely to be obese and hypertensive, whereas men with HFpEF had a higher prevalence of atrial fibrillation and coronary artery disease. And then when we examine the risk of heart failure that's associated with these conventional risk factors like hypertension and diabetes, we also see that there are notable sex differences. So for example, in community-based epidemiologic studies, hypertension portends a 3-fold greater risk of heart failure in women compared with only 2-fold greater risk in men. And the same is true for diabetes. Diabetes was associated with a 5-fold greater heart failure risk in women compared with 2.4-fold greater risk in men. So our group was really interested in understanding the role of obesity in HFpEF pathogenesis. And we did this by leveraging an international collaboration of 4 longitudinal community cohorts: the Framingham Heart Study, MESA, PREVEND, and the Cardiovascular Health Study. And what we found was that among 28,000 healthy participants from one of these 4 cohorts, obesity and insulin resistance were significantly associated with risk of future HFpEF, particularly among women, as you can see in the solid red line in this cumulative incidence plot. I think these data highlight to us the importance of obesity and other cardiometabolic risk factors in contributing to the development of HFpEF in women. So why do conventional risk factors more strongly predict HFpEF development in women compared with men? Well, to start, the typical pattern of age-related cardiac remodeling is actually fundamentally different in men and women. Female hearts adapt to a lifetime of pressure overload differently than male hearts do. In particular, pressure overloaded induced hypertrophy in women is associated with more accentuated concentric remodeling and more pronounced diastolic dysfunction, as you can see in the top panel. By contrast, in men are more likely to develop both concentric and eccentric remodeling, as you can see in the bottom panel. And this phenomenon has actually been consistently shown in epidemiologic studies. So at earlier ages, we see that men have greater absolute values of LV mass and wall thickness. And then with advancing age, we see that women actually experience a more accelerated increase in both LV mass and wall thickness. These are data from about 4,000 participants from the Framingham Heart Study who underwent longitudinal serial LV echocardiographic observations across a 16-year period. And I think you can appreciate that it shows exactly what I just described: higher baseline LV mass in men to begin with, but more accelerated and a steeper increase in LV mass with advancing age in women. Now, what I think is really interesting is this interaction between traditional risk factors and exposure to traditional risk factors and cardiac aging. So in the same Framingham Heart Study cohort, the investigators actually looked at longitudinal trajectories of LV mass in both men and women, but this time they stratified by burden of traditional cardiovascular risk factors. And here you can see that both men and women who had a higher cardiovascular disease risk factor burden also had higher baseline LV mass and greater increase over time compared with those who had a lower cardiovascular disease risk factor burden. But notably, women in both groups actually had slightly steeper slopes later in life compared with men. Now, not only do women remodel differently than men in response to conventional risk factors, we're also beginning to understand that female-specific factors contribute to HFpEF pathogenesis. For example, hypertensive disorders of pregnancy, including preeclampsia and eclampsia, were found to predict risk of hospitalization related to HFpEF. In this study here on the left, there were over 2 million women with delivery hospitalizations between 2006 to 2014 in New York and Florida states. And what the investigators found were that women with a history of preeclampsia and eclampsia were 2 times more likely to be hospitalized with HFpEF within 10 years from their initial delivery. Now, separately, our group has been really interested in examining whether infertility, an under-recognized reproductive risk factor, is also associated with future risk of heart failure. And although infertility is pretty underappreciated with respect to cardiovascular disease risk, it's actually pretty common. It affects about 15% of US women. And so we looked in the Women's Health Initiative, and we found that among 38,000 healthy women who were enrolled in the Women's Health Initiative, infertility was actually associated with greater risk of future heart failure, driven exclusively by greater risk of HFpEF and not HFrEF. Notably, this association actually did not appear to be explained by traditional cardiovascular risk factors or infertility-related factors. So I think the natural next question is, why? So we tried to shed some light on this question by examining the relationship between infertility and subclinical antecedents of HFpEF, including echocardiographic measures and cardiac biomarkers. And we found that among 2,000 healthy participants in the Framingham Heart Study, history of infertility was associated with a greater E to E prime ratio, which we of course all know is a non-invasive measure of elevated left atrial pressures and one of the parameters that we use to evaluate diastolic function. Now, these women were relatively young. The mean age was 41, and they were largely premenopausal. So that may have precluded our ability to look and really detect meaningful differences in subclinical cardiac remodeling. But I think our findings highlight this possibility that subclinical cardiac remodeling is accelerated in women with infertility. All right, so women, we've talked about how women are more vulnerable to developing HFpEF. Are there marked differences between men and women once an individual has actually developed HFpEF? And I argue the answer to this question is yes. Women with HFpEF have more clinical evidence of congestion and lower self-reported quality of life. These are data presented from a combined analysis of CHARM-preserved, I-preserved, and TopCat Americas that compared signs and symptoms of heart failure between men and women with HFpEF. And you can see here that women who are displayed in the red bars were more likely to report symptoms of orthopnea, PND, peripheral edema, and RALS, compared with men who are shown in the blue bars. And men more commonly reported JVD compared with women. Now, with respect to quality of life, women with HFpEF reported consistently worse quality of life compared with men. And specifically, what I mean by that is that women reported lower KCCQ scores and higher Minnesota Living with Heart Failure scores in these 3 clinical trials, consistent with lower quality of life. Echocardiography also seems to reveal differences between men and women with HFpEF. Compared with men, we see that women with HFpEF have lower LV mass, lower LV volume, but higher LV systolic function and greater impairment of LV diastolic function, including lower E prime and higher E to E prime ratio. And this was true even after adjustment for key covariates like age, race, ischemic heart failure etiology, and previous MI. What about biomarkers? Biomarkers also tell us that the HFpEF story may be different in men and women also. We know that sex actually impacts circulating concentrations of both BNP and NT-proBNP. In healthy populations, circulating levels of natriuretic peptides are actually twofold higher in women compared with men. But interestingly, the opposite is true for patients with HFpEF. Across large randomized trials of HFpEF, including TopCat, Charm Preserved, iPreserve, and Paragon HF, NT-proBNP levels were consistently lower in women with HFpEF compared with men. I think this observation is particularly notable given the higher baseline levels of natriuretic peptides in healthy women compared with men. Now, the mechanisms that we have to explain this relative natriuretic peptide deficiency are pretty poorly characterized, but some hypotheses that have been proposed include maybe there's lower wall stress due to smaller LV cavities in women, or maybe there's women's hearts have reduced LV compliance. So what is driving these sex differences in signs and symptoms and quality of life? Well, we tried to answer this question by examining hemodynamic responses to exercise in about 120 men and 170 women who had physiologic evidence of HFpEF based on a level 3 CPET in our MGH CPET database. In this analysis, we found that men and women with HFpEF actually exhibited similar exercise limitations as measured by peak VO2 and percent predicted VO2. And specifically, men had a peak VO2 of about 15.5, which translated to about 68% of their predicted VO2, and women had a peak VO2 of 14, which was roughly 66% predicted max VO2. And to put that in context, our heart failure colleagues know that the peak VO2 of a patient who's eligible to be listed for cardiac transplant is less than 14. So these patients are very limited. Now, despite similar functional capacity, women actually performed worse across all exercise domains. In particular, women exhibited worse peripheral oxygen extraction, worse RV and LV systolic reserve, and worse diastolic response to exercise. We next interrogated sex differences in arterial stiffness and their contributions to abnormal exercise responses in both men and women with HFpEF. One of the things that has been brought up in the past is that impaired endothelial and vascular function may be important contributors to disease pathogenesis in HFpEF. Previous studies have demonstrated actually that women have greater arterial stiffness at baseline compared with men, and that might be one of the reasons why women are more likely to develop HFpEF. So we compared baseline measures of arterial stiffness, including augmentation pressure, augmentation index, and aortic pulse pressure in both men and women with HFpEF. And we found that resting measures of arterial stiffness were higher in women compared with men with HFpEF. Then we looked to see if arterial stiffness was associated with abnormal exercise responses. And indeed, we found that arterial stiffness was associated with abnormal LV diastolic response to exercise in both men and women, but the association was more pronounced in women. So I think together these data suggest to us that arterial stiffness may contribute to phenotypic differences that we observe in men compared with women with HFpEF, and really implicates the vasculature and disease pathogenesis of HFpEF in women. Now, despite consistent observations that women with HFpEF exhibit more symptoms, greater functional capacity, worse quality of life than their male counterparts, clinical outcomes are paradoxically better in women. These are, again, data from that combined analysis of Charm Preserved, iPreserve, and TopCat Americas that I showed you earlier. And what you can see here is that the risk of cardiovascular death and all-cause death was actually significantly lower in women with HFpEF compared with men. And there was no difference in the rate of first heart failure hospitalization between both men and women. Okay, so I think, at least I hope that I've shown you that it seems like men and women with HFpEF seem to be fundamentally different. And I think that raises this question on many of our minds. Do women with HFpEF actually represent a totally different and distinct HFpEF phenotype? Here are data from a study of nearly 400 patients who actually underwent detailed clinical, laboratory, ECG, and echocardiographic phenotyping. And the investigators used hierarchical clustering analysis and model-based clustering to basically identify 3 distinct groups of HFpEF patients. And they had really different characteristics. So group 1 represented younger patients who had moderate diastolic dysfunction and relatively normal BNP. Group 2 included obese and diabetic patients who had a higher prevalence of obstructive sleep apnea. And group 3 included older patients with significant CKD, pulmonary hypertension, and RV dysfunction. And if you look at outcomes, you can see that the outcomes are pretty different. Group 1 had the best survival free of cardiovascular hospitalization or death, while group 3 had the worst. But I think what's really interesting about this study is that if you look at the proportion of women in each of these groups, 2/3 of the participants in groups 1 and 2 are women, highlighting this possibility that maybe there are some female-specific HFpEF phenotypes. And this idea of a female-specific HFpEF phenotype has also been observed in other phenomapping studies. This is an analysis of about 300 HFpEF patients, where investigators again used hierarchical clustering methods to try to cluster patients, but this time they clustered them based on obesity and inflammatory biomarkers. And they found 3 groups, which they labeled pan-inflammatory, non-inflammatory, and obese high CRP. The pan-inflammatory group had more comorbidities, they had more heart failure hospitalizations. Their overall biomarkers including NT-proBNP and fibrosis markers were higher. Their exercise traits were worse, and they were overall a sicker population. The non-inflammatory group had the most favorable values for all of these measures. And then the obese high CRP group resembled the non-inflammatory phenotype, except for an isolated elevation of CRP and overall lower functional performance. But again, you can see that women comprise 63% of the obese high CRP group, compared with only 45% of the non-inflammatory group. So I think these data give us some suggestion that there may be a unique contribution of obesity and inflammation to HFpEF pathogenesis in women, and provide some support for that paradigm I talked to you about earlier, comorbidity-driven microvascular inflammation as an important pathophysiologic mechanism with HFpEF. Okay, so far we've reviewed sex differences in HFpEF susceptibility and clinical phenotype. What are the therapeutic implications of these sex differences? Why does this matter to our daily clinical practice? Well, we're all aware that HFpEF represents a really significant clinical challenge, largely because we really have almost no effective HFpEF therapies. And this really highlights a greater therapeutic gap in my mind for women, given the higher prevalence of HFpEF in women compared with men. And on top of that, the systematic underrepresentation of women in clinical trials really limits the pool of evidence we have to guide therapeutic strategies in women with HFpEF. Now, despite these challenges, a few post-hoc analyses of 2 HFpEF randomized trials have actually hinted at potential therapeutic benefit of specific therapies for women with HFpEF. These are data from the TOPCAT randomized trial of spironolactone in individuals with HFpEF. And as you all recall, in the TOPCAT trial, treatment with spironolactone was not superior to placebo in reducing the primary composite outcome of cardiovascular mortality, aborted cardiac arrest, or heart failure hospitalization. But what's interesting is that post-hoc analyses found an interesting signal by sex. So there was no difference in the primary outcome by treatment arm between men and women, but there was clear heterogeneity by sex when examining all-cause mortality. Specifically, spironolactone was associated with reduced all-cause mortality in women, but not in men. Now, what are the underlying mechanisms explaining this observation? We really don't know. There have been some animal studies that have suggested that there may be a greater impact of MRAs on female hearts compared with male hearts, and maybe in the context of this TOPCAT trial suggest that potentially female hearts are more sensitive to aldosterone than male hearts are, but that's all very preliminary. Now, it really wasn't until the publication of the Paragon-HF trial, though, that fueled substantial interest in trying to understand sex-specific responses to therapy. As a reminder, in Paragon-HF, treatment with angiotensin receptor neprilysin inhibitor, sacubitril/valsartan, did not reduce the primary composite outcome of total hospitalizations for heart failure or cardiovascular death in patients with HFpEF. But notably, in pre-specified subgroup analyses, there was a suggestion of heterogeneity with possible benefit in two groups. First, in patients with lower EF, defined as an LV ejection fraction of less than or equal to 57%, and in women. And as you can see here, treatment with sacubitril/valsartan was associated with a reduction in the primary composite outcome compared with valsartan in women, but not in men, with a significant P for heterogeneity of less than 0.005. And when the investigators examined these outcomes according to sex, the benefit from sacubitril/valsartan in women with HFpEF was really attributable to a 33% reduction in heart failure hospitalizations in women with a P for interaction of 0.0046. Now, one hypothesis that has been proposed to explain these sex differences might be related to inherent differences in normal ejection fraction between men and women. So normal ejection fraction is really thought to be higher in women compared with men. So it really raises the possibility that maybe systolic dysfunction occurs at a higher LV ejection fraction range in women compared with men. So maybe an EF of 52% is actually abnormal in women, but normal in men. And so the investigators wanted to, interrogate this question. So displayed here are data from a pooled post-hoc analysis of both Paradigm-HF and Paragon-HF, which randomized sacubitril/valsartan to patients with both HFrEF and HFpEF respectively. And as you can see from this spline, the benefit of sacubitril/valsartan actually extends to a higher LV ejection fraction range, up to about 60 to 65% in women, displayed in the red line, compared with men, displayed in the blue line. Now, notably, effect modification by LV ejection fraction on the efficacy of sacubitril/valsartan was similar in both men and women. Finally, I think we were all excited in 2021 with the publication of the Emperor-Preserved trial that brought us our very first effective targeted therapy for the management of HFpEF. Emperor-Preserved found that SGLT2 inhibitor empagliflozin significantly reduced cardiovascular death or heart failure hospitalization in patients with both HFpEF and mid-ranged EF. And then Emperor-Preserved was followed very closely by the Deliver trial, which found a similar reduction in cardiovascular death and heart failure hospitalizations with the SGLT2 inhibitor dapagliflozin. But unlike with sacubitril/valsartan, there was no suggestion that the effect of SGLT2 inhibitors in HFpEF is modified by sex. And in fact, there were comparable reductions in cardiovascular death and heart failure hospitalizations in both men and women for both empagliflozin and dapagliflozin. Now, I think one of the most exciting updates in HFpEF management came out just a few weeks ago in the 2023 ACC Expert Consensus Decision Pathway. For the first time, expert consensus actually offered sex-specific recommendations for the therapeutic management of HFpEF. Now, class 1 therapy for HFpEF still includes loop diuretics for patients with fluid retention. And although SGLT2 inhibitors actually received a class 2A recommendation in the 2022 heart failure guidelines, given that the Emperor-Preserved and Deliver trial results subsequently were published, I think we expect that SGLT2 inhibitors will receive a stronger class of recommendation in subsequent iterations. And therefore, I think we really do recommend SGLT2 inhibitors for all patients with HFpEF. But I think the interesting part is that the authors actually acknowledge that there may be inherent sex differences in normal LV ejection fraction ranges, and they recommended consideration of adding on an MRA and or an ARNI for all women with HFpEF, but only in men with HFpEF and an LV ejection fraction that were less than 55 to 60%. This to me represents a huge step forward in translating sex differences research into clinical practice that really has not been done before. Now, for the last part of my talk, I'd like to spend some time exploring potential mechanisms that might underlie some of these sex differences in HFpEF. So as you recall at the beginning of the talk, I highlighted this leading mechanistic HFpEF paradigm that proposes that HFpEF is a comorbidity-induced pro-inflammatory state. So an important link between cardiometabolic risk factors and cardiac structural and functional changes is systemic inflammation. Now, immune responses are actually known to differ between men and women. I think the most illustrative example of this is the female preponderance of autoimmune disease. So I think that begs the question, can sex differences in immune response actually be explaining the differences we're seeing in HFpEF between men and women? So we tried to answer this question, and we did that by studying 71 cardiovascular protein biomarkers in over 7,000 healthy participants in the Framingham Heart Study. And what we found was that 86% of these biomarkers actually significantly differed between men and women. So interestingly, the biomarkers that were overexpressed in women, shown in red to the right, were actually enriched for biomarkers that are involved in inflammation and obesity-related pathways, whereas biomarkers overexpressed in men, shown in blue to the left, were enriched for biomarkers of fibrosis and platelet homeostasis. We're also really interested in understanding the role of inflammation and potentially mediating the association of comorbidities with HFpEF. Our research group has an ongoing effort to study eicosanoids. Eicosanoids are bioactive lipids that are derived from arachidonic acid, and they really regulate the upstream initiation of inflammation in humans. So we quantified 890 of these eicosanoids in the plasma of about 500 patients who underwent detailed hemodynamic assessment with invasive CPET at MGH. And we found that about 70 of these specific eicosanoid metabolites were actually associated with HFpEF status. Now, we hypothesized that some of these eicosanoids might actually highlight really important inflammatory pathways that may mediate this link between comorbidities and HFpEF. For example, we identified one metabolite called 8,9-EPETE, which is an epoxidation product of eicosapentaenoic acid. And we showed that this metabolite may in fact mediate the association between higher BMI with HFpEF. We're also interested in understanding, are there sex differences in these circulating levels of eicosanoid metabolites? And so we looked at this question in both the general population and in patients with HFpEF. And as you can see here, we see marked differences in circulating levels of these eicosanoid metabolites between men and women. This volcano plot actually displays multivariable adjusted associations of sex with levels of eicosanoids in about 5,000 healthy participants in the MESA study. And you can see that among 800 metabolites that we assayed, 45% of them were actually significantly different in men compared with women. About 250 of them were higher in women, shown in the pink diamonds. About 115 of them were higher in men, shown in the blue diamonds. And the same was true when we looked at HFpEF patients. So we looked at sex differences in eicosanoid metabolites in HFpEF patients in our MGH-CPET database. And again, we're seeing vast differences in pro and anti-inflammatory eicosanoids between men and women, with metabolites that are enriched in women displayed in red to the right, and those enriched in men shown in blue to the left. Now, I think these analyses are very much ongoing, and there remains a ton of work to do. But I think these preliminary data highlight to us the role of systemic inflammation in HFpEF disease pathogenesis, particularly in women. Now, of course, I think no discussion on sex differences is complete without a consideration of menopause and sex hormones. So what about the role of menopause and sex hormones in HFpEF? Well, the higher prevalence of HFpEF among older women and the greater susceptibility of postmenopausal women to develop LV diastolic dysfunction has led to this hypothesis that menopause-related estrogen deficiency may actually be an important contributor to HFpEF pathogenesis. We already discussed how the heart adapts very differently in men versus women. Specifically, as you recall, female hearts are more likely to develop LV hypertrophy in response to hemodynamic stress. Now, previous studies have shown us that actually lack of estrogen may enhance LV hypertrophy, whereas treatment with estrogen or menopausal hormone therapy may actually attenuate the development of LV hypertrophy. So for example, in a small case control study of 40 postmenopausal women receiving and not receiving hormone therapy, treatment with hormone therapy actually resulted in a 20% decrease in LV mass. Animal studies have also shown us that treatment with estradiol in overrectomized mice have led to improvements in LV diastolic function. So what are the mechanisms by which estrogen is purported to attenuate HFpEF development? This schematic represents 6 key regulatory processes and mechanisms by which estrogen may actually help protect against the development of HFpEF. So as you can see, estrogen actually reduces oxidative stress, endothelial dysfunction, and inflammation. It inhibits the activation of the renin-angiotensin-aldosterone system. It promotes natriuretic peptide production, and it attenuates fibrosis. And loss of inhibition of these pathologic processes due to the decline of estrogen during menopause is thought to contribute to the development of HFpEF in postmenopausal women. Of course, I think the mechanistic insights, as you can see, are really rudimentary, but it highlights a really important unmet need for us to systematically assess the association between menopause-related estrogen decline and development of HFpEF. So we tried to better understand this link between menopause with HFpEF, and we did that by examining differences in cardiovascular protein biomarkers between pre- and postmenopausal women. And we displayed these differences in this heat map, where biomarkers that are shown in red, are higher in women are shown in red, and biomarkers that are higher in men are shown in blue. So this first row displays relative differences in women compared with men. These are essentially the same results that I showed you earlier. Some biomarkers, including inflammatory and obesity-related biomarkers, are higher in women, and others, like fibrosis and platelet homeostasis markers, are higher in men. Next, we looked at premenopausal women compared with men. So if you look at rows 2 and 1, if you compare them, you can see that there are some differences, but overall the red biomarkers are still red and the blue areas are still blue. Now, how do biomarker profiles actually change with menopause? Well, we found that the biomarker profiles of postmenopausal women was actually more similar to men. So notably, the female-enriched biomarkers in red are still higher in the postmenopausal women compared with men. But all of those blue biomarkers, those male-enriched biomarkers, the differences now have been attenuated. And finally, I think the most interesting part was that administration of hormone therapy appeared to rescue the premenopausal biomarker phenotype. So now the biomarker profile of postmenopausal women on hormone therapy no longer looked like men, but instead like premenopausal women. So collectively, I think these findings show us that many, but not all cardiovascular pathways are influenced by menopause and hormone status. But if we can potentially isolate the pathways that are, that may help us better understand the pathogenesis of HFpEF. And then finally, we looked at protein biomarkers to help us understand why women with a history of early menopause might actually be at higher risk for developing heart failure. So we used that same biomarker platform in Framingham Heart Study, and we found that markers of inflammation, adiposity, and neurohormonal regulation were actually all upregulated in women with a history of early menopause compared with those who did not have a history of early menopause. Finally, I'd like to just give you a preview of some ongoing mechanistic work that I hope will help to answer some of these outstanding questions related to sex differences in HFpEF and the role of menopause. So right now at MGH, we have launched a prospective longitudinal research study that examines changes in inflammatory molecular profiles through the menopause transition. And we're actually looking at 3 specific inflammatory readouts: endothelial cell gene expression profiling, inflammatory proteomic profiling, and pro versus anti-inflammatory eicosanoid metabolites. And we hope that these findings may actually provide some novel insights into the changes that might occur during the menopause transition that make women particularly vulnerable to developing HFpEF. And we're really excited about this study actually because it leverages a novel protocol to isolate fresh human endothelial cells for transcriptomic profiling. And we'll be applying this technique in an entirely new patient population. And like I said, I'm hopeful that these will provide some mechanistic insights into the changes that occur during menopause. All right. So how do we put this all together? We've talked about a lot of things. Well, as we reviewed together, conventional and female-specific risk factors predispose women to HFpEF preferentially and may explain the greater prevalence of HFpEF among women. Now, once a patient has developed HFpEF, the clinical phenotype does seem to significantly differ between men and women. Women with HFpEF seem to have more abnormal diastolic function, lower natriuretic peptides, worse exercise parameters, and reduced quality of life, but somehow better clinical outcomes. While HFpEF-specific therapies are limited, highlighting an important therapeutic gap for women with heart failure, there have been hints that there may be preferential benefit from MRAs and ARNIs. And finally, do sex differences in immune activation drive the sex heterogeneity that we observe in HFpEF susceptibility and disease phenotype? And does menopause and related estrogen decline actually contribute to an acceleration in systemic inflammation that then contributes to HFpEF pathogenesis in women? So we're hoping to leverage molecular profiling to help us answer some of these questions. So here are our take-home messages. Just a summary of what we just discussed. Traditional risk factors and female-specific risk factors predispose women to HFpEF. In women with HFpEF, symptoms, exercise intolerance, and quality of life seem to be worse, but the prognosis is overall better. Women with HFpEF may derive preferential benefit from MRAs and ARNIs and should definitely be considered now after you've started a patient already on SGLT2 inhibitors. And finally, systemic inflammation and estrogen deficiency may explain the female susceptibility to HFpEF. And finally, I just want to acknowledge my incredible research team, including my primary research mentor, Dr. Jennifer Ho, as well as my clinical partners in the MGH Women's Heart Health Program, including Nandita Scott, Melissa Wood, and of course, my division chief, Patrick Eleanor. And I'd be happy to take any questions.
Was excellent, Dr. Lau. I wanted to open the floor for questions.
First of all, I would just second that was a wonderful talk. Thank you very much. You know, have the traditional risk factors been looked at on a continuum rather than as dichotomous variables? So to put it in context, at the time of diagnosis of HFpEF, is systolic blood pressure different in women and men, and do they have a longer antecedent history of kind of area under the curve for various risk factors? Same for obesity. And do some of these apparent differences diminish or perhaps get accentuated if those risk factors are considered as continuous variables? Second question relates to the infertility issue. Is it explained by prevalence of PCOS and the accompanying metabolic syndrome that frequently is seen with PCOS? Thanks.
Yes, thank you. To answer the first question, I think that that's such an important question. It's actually, I was just chatting with Judy Regensteiner about how we really don't understand. I know, she's right up there. We were just chatting about how we really don't understand whether or not the same, for example, blood pressure threshold that we're using affects women and men differently. There's actually been some really interesting work out of Cedars-Sinai that showed that women actually start to develop cardiovascular disease risk at a much lower blood pressure range at an earlier stage in life. I mean, we're talking about in their 20s and 30s, and that just continues to be the case throughout one's lifespan. In our MGH-CPET cohort, so all of these patients are referred for a level 3 CPET. They come to us and then we define whether they have HFpEF based on physiologic criteria. And we found, interestingly, that women seem to have a lower comorbidity burden. So at first we were really confused because all of the data showed us, right, that women with HFpEF have more comorbidities. But actually, if you flip it around and think about this, that women with fewer comorbidities are already presenting with functional exercise limitations, with the diagnosis of HFpEF. So they're developing HFpEF at a much lower burden of cardiometabolic disease than men are. So it really, I think, begs the question that we need to do more investigation into what is the cardiovascular risk that's conferred by conventional risk factors in women compared with men. They may be very different, and we don't know the answer to that question, and certainly none of our targets are sex specific. They're all sex agnostic. And then to your second question, that was exactly, we're sort of wondering, well, what's the cause here? So we did try to better understand that question as to whether or not there are specific causes of infertility that really drove this greater risk of heart failure. And we did find nominally that there were higher rates of heart failure among women with either a hormonal or ovulatory reason for infertility. There are other reasons like structural reasons that there's no difference in heart failure risk. But interestingly, when we did adjust for cardiometabolic risk factors like diabetes, obesity, things like that which we would associate with PCOS, we didn't see an attenuation in the association. So I think it's probably a combination of, yes, women with infertility, particularly those with ovulatory hormonal dysfunction or PCOS, may more likely have cardiometabolic disease, which then contributes to heart failure. But there may be something inherently different also pathophysiologically about women who have a history of infertility.
I'm going to get to everyone here. Dr. Regensteiner has her hand up.
Oh, great talk, Emily. It was just really fantastic and well thought out and provocative. We also have found in women with type 2 diabetes compared to men with diabetes, if you compare both groups to their non-diabetic sex-matched counterparts, that women's exercise performance if they had type 2 diabetes was worse than their male diabetic counterparts. So that's just very interesting to have seen those data in your heart failure folks. What do you think about the estrogen story? Hearing about the infertility, hearing about the, your findings or your thoughts about estrogen. Is there any plan to do prospective studies with estrogen? I mean, estrogen kind of went into, hiding after the Women's Health Initiative, but it turns out there are a lot of reasons why it might be important to study it. But I'd just like to hear your thoughts about future estrogen investigation.
That's such a great question. Larry and I were just chatting about that this morning. Because the WHI results in the sort of early 1990s basically showed us that there might be paradoxical harm, it's been very hard to find a way to relitigate this question. And for folks who are not familiar with the estrogen literature, there was this huge pendulum shift, right? First, before the Women's Health Initiative, every woman was on hormone therapy for not just treatment of menopausal related symptoms, but actually for the prevention of cardiovascular disease. And then after the WHI and some other trials like hers, the pendulum shifted entirely the other way. When I was in medical school, nobody even taught us about hormone therapy because it was really thought to be this big black box. Now, I think the pendulum's come back a little bit toward the middle. There were two randomized trials, which Judy, of course, is very familiar with, that was sort of in the early 2010s, that looked at hormone therapy and subclinical cardiovascular disease in younger women who were more close to their menopause transition. We actually found that first there was no harm and maybe even potential benefit in reducing subclinical cardiovascular disease. So I think, now we say, well, it's probably safe to be on hormone therapy for women who are in that early postmenopausal stage for treatment of menopause-related symptoms. But I think the outstanding question remains, is there actually true cardioprotection? And I think it would be really interesting to see if we might be able to, after we recruit this longitudinal study, could we think about an intervention arm? Does estrogen actually mediate one of these eicosanoid metabolites that I showed you? And is that a pathway that, may actually translate to improved cardiovascular events? I think it's very hard to think about randomizing estrogen for large outcome trials today. But I think certain physiology studies may offer us an opportunity to try to reopen this question that's basically been closed shut for so many years.
Hi. I have a questions regarding the inflammatory response in female. That's because of recently I have the opportunity to work on a subpopulation of top met data called HFpEF, and this patient they have dilated cardiomyopathy, and the same observation that I have is immune response came out to be the top pathway activated in female compared to male.
Mm-hmm.
However, then my question is, it's activated in different diseases, HFpEF, and also other, let's say, other diseases. Is this really inflammatory, the primary effect, or there is another yet to be discovered primary effect in female that what is your thought on this?
Yes, I mean, the chicken and the egg is always sort of the sentinel question. I think what's nice about our effort to really characterize eicosanoids as a sort of inflammatory readout is that we know that eicosanoid metabolites actually mediate the upstream initiation of systemic inflammation. So, it's always hard, I think, in these studies to really establish causality and the direction by which is inflammation the causal factor, or is it really just a secondary bystander? But we do know that eicosanoids start inflammation in women. So if we are seeing differences, or not just women, in humans, but if we are seeing differences, it may help us glean a little bit more, it may give us a little bit more confidence in saying, actually, inflammation is the driver. Now, it doesn't necessarily mean that it can't also be the sort of the chicken, right? That it can't be the downstream consequence, because we don't yet understand the complicated pathways of, like, can eicosanoids, they mediate upstream initiation, but then do they also interact with downstream inflammation? We don't know that yet.
Really nice talk.
Thank you.
Acknowledging that there are many physiologic differences that have been identified between men and women, at least on average, I have to say that the differences that you showed are not dramatic. And the dramatic limitation to exercise functional capacity that we see, I think, could not be attributed to those relatively small differences. We also know that previous criteria used to define HFpEF have poor sensitivity and specificity. Attribution is often erroneous, may have contributed to negative results in prior trials. And in fact, very recently released guidelines emphasize the importance of identifying objective criteria of structural and functional abnormalities of the heart. So I just wonder whether by focusing on sex as a dichotomizing variable to distinguish therapy, which is really where most of us are focused these days, whether instead what we should be doing is more detailed physiologic profiling on our patients. We know that this is not a monomorphic disease entity. And in fact, calling it HFpEF probably detracts from the diagnosis and treatment and management of these patients, because it suggests that there's one problem that requires one solution. And we know that these patients are often as limited or more limited by their comorbidities than they are by heart failure. I have put that term in quotes here. So by doing detailed physiologic assessment, for example, exercise right heart catheterization, to try to determine whether it is in fact congestion at baseline, or whether it's exercise-induced congestion, or whether it's deconditioning by doing CPET and things like that. Would that perhaps not be a better approach to dealing with these patients across the sex spectrum?
I couldn't agree more. I think our current understanding of HFpEF is so crude, and it's just as you say. I think that we use HFpEF as an umbrella term to really, it probably represents numerous phenotypes, not just 1, 2, 3, but probably multitude of different phenotypes, in that HFpEF really represents the end stage sort of result of many different pathophysiologic pathways. I think for a long time, because we didn't have any therapies, partly we didn't have therapies because we're probably treating different types of diseases, but because we didn't have any therapies, there didn't seem to be an impetus to try to better characterize these patients. But now with the advent of SGLT2 inhibitors, it may behoove us to think, should we be thinking about, I mean, because we aren't doing detailed hemodynamic phenotyping in most of our HFpEF patients, right? Most of them are being diagnosed clinically with some very crude parameters. But perhaps, as you say, that now that we have therapies and they're also like we are beginning, we know more and more that this really is a grab bag condition, that there will be information gleaned from more precisely defining the phenotype. I think, when I think about sex-based differences, I really think of it as still quite crude. Like, I think our ultimate goal is to offer precision and personalized medicine to our patients. And I think that sex-based therapeutic recommendations are really just one tiny step towards being more personalized, if that makes sense. But I completely agree. I think that you just captured so eloquently and brilliantly what is the challenge about HFpEF, and probably the reason why we don't understand it. We don't have very many things to treat it, because it's probably so many different disorders.
You showed really interestingly that women with diabetes have this much higher susceptibility to heart failure than men. I was wondering if you've looked at whether gestational diabetes, which obviously is uniquely female, is that partially driving some of this, or whether there's a difference between women who develop gestational diabetes versus women who develop more, I suppose, traditional type 2 diabetes?
Yeah, that's a great question. There's been a lot of work looking at the relationship between gestational diabetes and cardiovascular disease writ large, not necessarily heart failure specifically, and there's absolutely a significant association. Most people think, though, that that it's really mediated by the development of later life diabetes. Because I think over 50, probably more than that, 50% of women who have gestational diabetes will then go on to develop type 2 diabetes later in life. But it would be very interesting to understand whether or not gestational diabetes in and of itself is an independent risk factor. And there is some suggestion that that's true. So what is mediating the rest of it? I don't know that we know the answer to that, but I think it's sort of the same concept. Are we seeing, for example, robust systemic inflammation and these downstream, sort of abnormal cardiac remodeling responses? That's a great question.
All right, we're at the top of the hour. So I wanted to thank Dr. Lau for coming all the way from Boston. It was a really long flight, I hear. But thank you all for a great academic season. I wish to see you at Blount. And if I don't, I'll come after you. And then we'll restart again in the fall. So send me suggestions for next year's Blount, because they actually want people. I need to actually give them a name pretty soon. So thank you.